to the third of our 7 great presenters events this year. Tonight's speaker is Dr. Ruben J. Azocar, Professor and Chair of Anesthesiology and Perioperative Medicine at Tufts University School of Medicine. Dr. Azocar obtained his medical degree from the Universidad Central de Venezuela, completed his anesthesiology residency at BU Medical Center, and critical care fellowships at Cook County Hospital and Beth, Israel. Dr. Azocar is the president of the Society for the Advancement of Geriatric Anesthesiology and has a clinical and research interest in the care of the older adult presenting for surgery and anesthesia and/or suffering from critical illness, which is the topic of tonight's presentation. We're privileged to have him here tonight, so please join me in
Well, thank you very much. First, I'm honored to be here tonight. Thank you for Steve Engler to invite me and Courtney to arrange. I would also make a special thank to two very special people that are here tonight. So Don and Kathy Michael are my American parents, because despite my heavy Boston accent, I'm from Venezuela, and I came to the States to study English at the American Language Academy that was in Babson College, and I was lucky enough to be so young that I couldn't live in the dorm, so they assigned me to this wonderful family, and they are really my parents, and a lot of my life and success on the States are indebted to their example, dedication, and help through the years. So thank you, Kathy. So I'm also, this is one of my topics that I'm really passionate about it, because I think this is one of the paradigms in healthcare that are most important nowadays, to understand what's the impact of the growing population over 65 years of age in healthcare. And with the advances that we have in surgery and anesthesiology, we're able to provide care for them, but things are not quite perfect. And I think also that when we talk about anesthesia surgery, we talk about teams, surgeon with anesthesiology and the nurses, but I think more and more it's very important that the patient is integral part of the team and understands what's happening and be part of the process. And understand the surgery and anesthesia are not the moment when you're having surgery, but now we're trying to talk about the period around that. We call it the perioperative period. And I'll talk a little bit about that, especially the preparation before the surgery. I have no disclosure financially, but if any of you have an interest in helping me get out of that situation, I'll be glad to talk to you at the end of the lecture. And my other disclosure, I'm the president until January of the Society for the Advancement of Geriatric Anesthesiology. We're trying to really enhance the care that is provided to the older adult presenting for surgery and anesthesia. So a little bit, I touched on this already. I'm going to walk you through the demographic of the aging population in the United States and the impact on healthcare. I'm going to review some of the outcomes that we have and try to understand some of the factors that are related to those outcomes, and also how can we maybe improve these outcomes. I'm going to try to make also this interactive, so I might be asking you questions, and I intend to not go over 35 minutes on the slides and leave a lot of time for question and answers, which I think might be more interesting, and maybe we can discuss some other topics related to this or any questions that you might have. So the first question is, if you were to have anesthesia surgery, are you worried about it?
Yes.
And what would worry you? What are the things that makes you scared?
I had surgery and the anesthesiologist didn't take me deep enough.
Okay.
That was a worry.
I've had problems with anesthesia, so when I go in next time, I'm terrified.
Okay.
It's gonna happen.
Anybody else? Any?
I want to come out of it.
You want to?
Yeah.
Okay. Well, I have an anecdote when I think it was my first year as a resident at BU, and the Michaels had me for Thanksgiving, and Don say, "Oh, this is my Venezuelan son. He puts people to sleep." And I say, "Well," and I'll wake them up. Okay. And have you heard of the term the gray tsunami? The Great Tsunami is related to the changes on demographics. So in 2010, the so-called baby boomers start turning 65 years of age. Right, at that time, only 13% of the population was older than 65. From that year on, every day in the United States, about 10,000 people turn 65 years of age. As a result, in 2015, we had almost a 4% increase. Right? In 2020 will be 16% of the population, and about 2030 will stabilize around 20% of the population. But not only that, we're turning 65 years and older, but we also live it longer. So this is people that's going to be 100 years of age, but year 2050 is going to be a growth eightfold of people that might reach the age of 100 years. And this is not a doctor talking, because the first people who looks at these changes and try to predict trends are the people in the business and the bankers and all that. So this is the Prudential, and sorry the photos didn't come up on this really well, but this was a demonstration in Chicago, and they asked, how's the oldest person you know? And if you look at here, around 90 years of age is the peak of people knowing, or the most people that people will know that were around 90 years of age. And not few of them were around 100 already, and even older than 100. And experts now are recommending in Prudential that you save enough to live to be 105 years old. So I could find my financial advisor. I'm talking to my wife Mariah, say, well, Ruben, I don't know, but you certainly will live much longer. And now the other thing that has been very interesting for me on this topic is that the approach or the perception or the expectations that people have on the population over 65 or what healthcare should be is much different than it used to be in the past. So people in the past will say whatever the doctor said. Now people want to be really more proactive. You have more information. We have the internet. You might have a higher level of education. There's a lot of competition on the market. There's a lot of technology out there that is advertised. There is direct-to-consumer sales of medications on television, so you can see which medications might be coming out for different, from dementia to erectile dysfunction to other things that might be common in the older adult that are directly sold. So you have a lot of more information and a lot of higher expectations of the healthcare system that probably people had in the past. But what is one of the problems we're having in this country is that this is the healthcare spending GDP from 1980 to 2011, and the United States, as you know, and probably had heard, were the most expensive healthcare system in the world, compared with other countries like Holland or France or Germany that provide similar levels of healthcare, but we are certainly the most expensive where the healthcare is more. And one of the reasons is that, or the differential is that the consumption and healthcare use after we turn 50 years of age is really much higher in all of these countries. And you've probably seen things like this where a smaller amount of the population might consume a lot of services on healthcare, and that's no different on the surgical world. So on this data from the census, from 94 to 2005, there was a significant increase on procedures performed in people over 65, from about 6.5 million a year to 7.3 million. About 35% of surgeries performed in those older than 65 years of age. And basically, the expectation is that before we die, we're going to have some procedure. It could be a colonoscopy or a cataract, but each people over 65, before they die, they'll have something done that might require an intervention. And it can be a minor intervention, but they also will require some sort of sedation or a full anesthetic. And how do we do it? So anesthesia has become really safe over the past 50 years, and the chances of dying per million, and blue is male, red is female, is not politics, just gender. The chances for you die are really low, but once you turn the group about 55 to 60 years of age, the chances of you dying after anesthesia increase significantly. And this is no different also in the our surgeons' counterparts literature shows the same. So blue is complications after operations, and red is mortality. And again, the complications are relatively low, but once you enter the 50 to 60 range, the complications tend to appear more frequently, and also the mortality increases. So we have a population that's getting older. We have the technology, the resources, the medication to provide care for them, but we're not doing great on the outcomes we have. And there might be many reasons for this. And I tried to classify them in 4 different ones. And I apologize, we had a little bit of technical issues, so I didn't realize they were so clear. But basically I want to talk a little bit about age issues, about coexisting disease or comorbidities, the type of surgery, and the functional status. And a lot of the things I want to talk about will circulate about this. Obviously, the type of surgery is the easiest one to explain. It's not the same to have a cataract done than to have your aortic valve replaced or having a tumor removed from your brain. So depending of a low risk, intermediate risk, high risk, that will have a correlation with what kind of outcome you might have. What about age itself? So the process of aging happens in all species and basically affects all the organ systems. And even when in health, you're going to have a decline in function. So if we start with the central nervous system or the CNS, you're going to have changes on the neurotransmitters, the substances that help your brain nerves connect. You are going to have decreases on the perfusion of your brain. The sleep cycles might get a little out of control, so you might be waking up in the middle of the night if you're really tired at 4 or 5 in the afternoon. From the cardiac standpoint, where it's mostly, or the most frequent organ system that gets affected as with age, this problem of getting really stiff, so your heart gets stiff, so it's very sensitive to too much fluid. Your arteries, your pipes going to your heart also get stiff, so you can require cardiac surgery. Tend to have high blood pressure, and again, this is one of the most frequent causes of a disease in the older adult. Your lungs also become stiffer, your chest wall, the bones and your chest get a little arthritis, so you cannot expand your chest as much as you want, so you lost some of that respiratory capacity that you have when you're younger. Your kidneys lose ability to filter the blood as well and to reabsorb the water, so people in the older age tend to get dehydrated more easily. And in terms of the drugs, people get more sensitive, or you might lose some of the capacity to clear the drugs out of the system. And not infrequently, many people is on 4, 5, 6, 7, 8 medications, and those medications might have interactions. And then when you add an anesthetic, all those interactions might create a problem. So basically, what happens with age? And if you think about, this is everybody at baseline, and assuming that you don't have, that you're completely healthy, you'll see a decline in the function. But in reality, what we lose, most importantly, is the functional reserve. So if this is the function at a stress, let's say that you are in an accident, when you're 25 years of age, you're going to respond really well to that stress, and you probably will recover. When I work at Boston City Hospital, these kids will come with a bullet on their belly, and they have a horrible operation. 3 days later, they're getting the tubes out of their mouth, and they want to eat, and they're ready to go. People as getting older will spend weeks and weeks on the ICU because you lost this functional reserve. So at baseline, you might be feeling great, right? But if you have a stress, your ability to respond to that stress might be impaired. And that's part of the regular aging process. And we're going to get back to this slide in a little bit. What is the effects of having coexisting disease? And again, this didn't come quite perfect on this slide, but basically if you're young, less than 34 years of age, and you have 1 or 2 or 3 diseases, your chances of having a complication is relatively small. As we get older, 1 or 2 coexisting issues will increase your chances of getting complications significantly. So if you have high blood pressure, diabetes, you're a smoker, all those things will have a much higher impact on your possibility of having a bad outcome than if you have the same disease and you're younger. And what we can do about that, and this is very important, is the preoperative evaluation, and you might hear the anesthesiologists do it, some of the surgeons do it. So on the things that I want you to remember and maybe ask, the American College of Surgeons on their website, and I'm pretty sure I have the link there, has a risk predictor scale on the internet that you could access as a patient, and you can ask your surgeon about it. And basically, what you do, you go online to the American College of Surgeons website, and you can enter what kind of operation you're going to have, some of your demographic information, some of, I'm sorry, let me see, going back again. So if you're diabetic, if you have hypertension, if you have some other comorbidities, and then the computer will give you a result of what's your risk factor to have a complication. So this is a great point of information to bring to your surgeon and ask them, because part of the information that you might want to add that might be difficult for you to interpret is how risky the operation is. And sometimes the same operation might be riskier in somebody than in other people for different reasons. So if you had cardiac surgery before and you need another cardiac surgery, your risk is much higher. But that's something that only the surgeon could determine. But I think, again, on the partnership that I believe patients should have as they come for surgery and anesthesia, this is a great website to have. And so here's the link. And I can leave the slides with Courtney so you can have access to them at any time. However, a term that is coming more and more in the literature is frailty. So, and frailty is the lack of physiological reserve across multiple organ systems. So it's related to what I spoke about before, about how much functional reserve you have. But the problem is that age itself is not a great determinant of how frail you are. So you can have a 75-year-old guy that's going on tour again, right? And you can have a 75-year-old that is already in a wheelchair. And the functional reserve that these people is completely unrelated to their age. So the concept of frailty is taking hold because we can adjust your comorbidities. So if your blood pressure is out of control, we can control it before surgery, or fix your sugar if it's too high before surgery. We cannot really change your age, but can we fix your functionality to a certain degree? And how can we mix frailty? It's something that is coming up on the literature, and this is from the American College of Surgeons, that says, well, if you're what they call intermediately frail, your chances of complications are twofold. If you're frail, it's 2.5 times. You're going to stay longer in the hospital, about 1.5 days longer or 1.6 days longer, depending where you fall into this category. And for me, even more importantly, the chances of you going to an assisted facility or rehab instead of going home, if you're coming from home, are 3 times higher if you're intermediately frail, and 20 times more if you're frail. So this has significant impact, because for me, it's not only the quantity of life, so you might die on your operation, but also having a bad outcome in terms of requiring a prolonged stay in a rehab doesn't help in the overall situation. And this is another slide saying, we doctors might like to put all the papers together and try to get a summary. So 23 studies show that people that are older and they're frail have more mortality, more complications, and stay longer in the hospital. Now, this concept doesn't only apply to your physical activity, but also to your brain. And this is a graph that basically says if your brain reserve is all this much and you have an insult, let's say you had a stroke, but your cognitive reserve is high, you might have this protective factor here, that little thing that is going to allow you to recover. Whereas if your functional capacity is decreased, you might have never come out of that critical zone and never really quite recovered after a stroke. And it's well determined that people that have cognitive activity, and I'm going to talk more about it when we talk about rehabilitation, but this paper look at people that either sing or play computer games or do knitting or call their friends more frequently, and they have some sort of activity, they had less amount of complications from the cognitive function in terms of losing cognition or being delirious on the hospital and so forth. So having that reserve is very important. So it's not only your physical capacity, but your cognitive capacity also plays a role. And a little bit, as I mentioned before, you know, there is plastic surgery, but you're 65, you're 65. Your coexisting diseases we can't control, we cannot cure, right? You're diabetic, you're a diabetic. You had a heart attack, you had a heart attack. We can make you the best we can in terms of, you know, making them be as good as possible. The surgery is the surgery itself, but can we change the functional status? So one of my Boston heroes here, Bill Rogers. So having surgery is a little bit like doing a marathon or doing a 5K or a 10K, depending on the surgery you're going to have. So the questions are you fit for the race, right, or are you fit for surgery? And I think this is what I'm going to spend some of my time here in the next few slides. Because the concept that we're bringing forward is the concept of prehabilitation. So can we train you a little bit before you come for your operation so that you increase your physical capacity and maybe your cognitive capacity? And why is that? So let's assume this, I don't know, it's red on my regular slide, but kind of purplish line here. This will be an older person coming, and they have surgery, and they get a little debilitated. Maybe they go into this critical zone, so you might need to be in the ICU for a few days, or go to rehab for a few days, and then you recover. And this may be somebody that's frail. You know, we discussed frailty a little bit, and they will have a course where the critical zone might be prolonged, and they might not even come out of the critical zone. And you have somebody that maybe you are an older person going for surgery, and I'll give you a little bit of this prehabilitation, so when you come into your surgery, you don't even touch the critical zone. And one of the things that I love about English or the United States is the acronyms.
Thank you.
Do you know what, in medical terms, what a CABG is? Does anybody knows? So a CABG is a coronary artery bypass graft. When I first came to the rotation of the Boston VA, somebody came and say, Mr. Smith had a CABG. And I think, well, maybe he has some sort of indigestion or something. They had to be admitted. Yeah, that was a few years back. But we came, or my friends in Canada and one of my colleagues on SAGA from Johns Hopkins came out with this acronym called Nutrition, Exercise, and Worry for psychological. And in the exercise, we include both the physical and cognitive exercise. And I'm going to speak a little more on this slide, because I didn't want to bring all the papers for the literature and bore you to death. But one of the things is that we're seeing is that these things correlate to each other. So some of the papers that are showing that having some exercise before you have to your surgery not only improves your physical response to the operation and anesthesia, but also might have a good effect on your cognitive function. Or where papers are saying if we give you a better nutrition before surgery and some exercise, you do even better than it's only one or the other. So I think that we're going to be seeing more and more of this. At Tufts Medical Center, for example, we started 2 years ago a program of, I'm going to call it super nutrition for this audience, but it's basically an immunonutrition to help your body respond stronger to surgery. So if you come to Tufts Medical Center and you have a hip replacement or a knee replacement, we'll give you a 5-pack for 5 days of immunonutrition that you need to drink before your operation that would help. And for example, we've seen that the infection rate has come down because that nutrition hopefully had helped enhance your wound healing and your response to the stress. We're also doing more hydration before surgery. We have struggled with the concept of exercise, but more and more literature is coming that even minimal amount of exercise might be enough. Some people are talking about an hour of exercise 3 times a week for 2 weeks might be enough to get you just a little better to make a difference. In terms of the word, I love this because Kathy always told me about the body and the mind when I was being a medical student. And good data suggests that people who come with stress, of the operation doesn't help you. Stress has a negative effects on your body systems, including your immune response, which is key for you to recover. So there is some good data coming from different countries talking about stress, meditation, relaxation techniques. In younger patients, they talk about video games or virtual reality. And also telling the patient more about the expectations of what's going to happen when you come for surgery and anesthesia will help alleviate that anxiety that you might have during the anesthesia and surgery. So you're going to see more and more of this maybe coming. And this might be a good question to ask your surgeon and your anesthesiologist. Anything that we can do dietary-wise or exercise-wise that might help. From the cognitive exercise, how many of you have Luminosity is an app for cognitive games? Anybody? No? Nobody? You do have it? Okay, so there's literature now coming out from Ohio State and the Beth Israel on giving patients an app on your phone to play games. And we don't have the results yet. I did part of my training with them, so that's how I know of the study. And they're trying to see if that will prevent cognitive dysfunction after surgery and anesthesia with you doing a little bit of brain exercises beforehand. And the good thing is that they can track you, right? So you cannot lie and say, yeah, I walk a couple of miles every day. Well, we're gonna get to that in a second because who of you doesn't have a smartphone? You do not have a smartphone.
No.
Okay. 3, okay. Because, you know, part of the tracking, and this is again part of the patient partnership, and this is colleagues from the University of Michigan who run one of the largest quality programs in the country right now. You come for surgery, they're gonna put an app on your phone, and the phone will track your activity, and maybe remind you to take your immunonutrition, and maybe remind you to take 5 minutes to breathe slower, or do a little meditation in the middle of the day. So technology, and I now have this, who's telling me that I didn't exercise enough today already, because I've been at work all day. So there'll be more technology coming up where will help us kind of do this partnership where the patient will be prompt to exercise, will be prompt to take their immunonutrition, will be prompt to have a minute of meditation, mindfulness before the operation. And also there are a lot of resources from our societies. The American Society of Anesthesiology created a Perioperative surgical home, which is aimed to try to maximize patient outcomes by decreasing cost of healthcare, because the better you do, the cheaper the healthcare we provide is. So if you go home faster, if you don't have to go to a nursing home, if you don't have to be readmitted, if you don't have a wound infection, healthcare costs will come down. When I was chair of the geriatric committee at the ASA, we established the Brain Health Initiative. So it's also a resource online. We will explain to you what to expect, or what are the risks of somebody presented for surgery in terms of having acute cognitive issues, we call them delirium, or what is the data of long-term cognitive function problems that you might have. Our surgeons colleagues have also the Instagram for Surgery website that talks about, so there is a patient link in all these sites that you can connect and get some more information and educate yourself about things and questions to ask your surgeon or your anesthesiologist. And as I promised, in 35 minutes, the great tsunami is here, and more procedures in the older adults will come with it. Surgical outcomes in the older adult are not as good, and if you're frail, they're worse. It's multifactorial, but functional capacity could be modified. Rehabilitation might improve outcomes. We are on the early stages of doing research on this area, but patient participation is key. And after surgery and anesthesiologist, am I ready for surgery? What are the risks of benefits? Please mind that I'm not saying not to have your surgery. You might need your surgery not to be frail, because if you are unable to exercise because your knee is killing you, that's not good. If you cannot move because you need heart surgery, that's not good. But be sure that you are having your surgery in the moment that is best for you, so that you can have the best outcome process. Thank you very much again for the invitation. I hope you like, and I'm leaving time for questions. Yes, sir.
At a basic level, doctor, what does anesthesia do to the brain and to the heart?
Okay. So there are different receptors on the brain with anesthetics work. Some of them we know exactly which receptors are. For example, for medications that are Valium-like or morphine-like, we know. The inhaled anesthetics we use, the gases, we don't really know exactly how they work. There are several hypotheses. And some of the drugs we use intravenously, like propofol, the Michael Jackson drug, we also are not sure how it really works. We know some of the receptors that it affects, but the exact mechanism how it works, we don't know. In terms of the heart, your heart is basically a pump, and you might have three problems. You don't have enough water coming to the pump because you're dehydrated. Your pump might be broken. You have heart failure. Or then the exit of your pump. You have too much water coming out, and that might be in a situation like an allergic reaction or a severe infection called sepsis, where there is no enough pressure to contain the water coming out of the tank. Or you have a constriction of the arteries, so the pressure in your heart are too high. The anesthetics will create low blood pressure because they create all the vessels in your body to dilate, so your pressure will tend to come down. But they also might have effects on the pump of the heart, so your heart might not contract as well. So those are the main effects that happen on the heart. The question in terms of cognitive dysfunction and anesthesia is an interesting one because we believe that if you get acutely delirious, there might be medical factors affecting that, including pain, but also if you wake up after anesthesia and you don't have your glasses on or your hearing aids if you need some and you're a little disoriented, you might get delirious. There are some medications that we use and now are preventing to use in the older adult, like the Valium-like medication that have been known to produce delirium. And then the question is, that's acutely, that might happen in the recovery room the first 2 days in the hospital. But then we have what we call cognitive dysfunction, which is a longer-term disability. I'm gonna use the phrase that people say, but Uncle Tom wasn't the same after his heart surgery, and people might lose some functionality. The largest paper on that showed that at 6 months, everybody pretty much returned to baseline, and those who didn't tend to have lower levels of education, have some pre-existing cognitive dysfunction, or have depression or substance abuse. So it seems to be some risk factors associated with that. There was a paper in the Nordic countries, I think it was Sweden or Denmark, where they took twins, and one of the twins over 65 would need surgery, and they compared the twin with the twin, and at 6 months, most of the people look the same. So it's kind of uncertain, whereas anesthesia surgery itself might cause the damage, but also where some patient predisposition factors play a role, and also what kind of surgery you have. If the surgery is controlled and it's not a major surgery, and the inflammatory factors are not as much, your chances might be less to have cognitive issues, but if you had a larger surgery, trauma, complicated cardiac surgery, maybe your chances of having some cognitive functions in the long term might be higher. Yes, ma'am.
I would like to know what are the correct questions to ask if you are going to have anesthesia, because I've had occasions where, for instance, for a colonoscopy, they've already relaxed you, and then the man comes in and says, well, here's what we're going to do about your anesthesia. And I feel like that's pretty late in the game. And do you have options? Does a non-medical person have options?
Yes. So anesthesia, we call it a continuum of levels of what I call consciousness and awareness. Right? For procedures like colonoscopy, we use something that we call a monitor anesthesia care. You might hear it say, I'm going to send you to the Twilight Zone, or you'll be in La La Land, you're going to be a little sleepy but not quite, are terms that we use. In those cases, we're giving you most of the time something like propofol that is quick acting, quick relaxing, and it gets broken down by the body pretty quick. We don't put any breathing tube in your mouth or anything like that, maybe only an oxygen mask. If you're gonna have major surgery, you have two options. And one that we call regional anesthesia, and that's fairly limited to your limbs, where we can put a needle and inject, like Novocaine-like, like the dentists do, in either close to your nerves or in your spinal cord, and then you get numb. We're doing a lot of the total joints like that at Tufts because there is some data that maybe suggests that since we are only using something local and not giving you a lot of other medications, maybe your cognition issues might be less. The literature is sort of like plus minus. My personal experience is that yes, it makes a difference, but we call that anecdotal medicine, anecdotal data. Most of the people, I think, in the geriatric world, we believe that makes a difference, but we don't have enough literature on that. Or you can have a general anesthetic, which basically you're completely under. We need to control your respiration. You probably have breathing too. At times you might be breathing by yourself. Sometimes we need to activate the ventilator. So those are basically the three options. So deep sedation or monitor anesthesia care, some sort of regional anesthesia, and a general anesthetic. The question is, how we do decide is a combination between what kind of operation you're going to have. You cannot have cardiac surgery with sedation only, and probably having a general anesthetic for a colonoscopy is an overkill. And also patient preference, surgeon preference, and where the operation is going to take place. So it's but I think you could ask, if somebody tells you you're going to have X, it's your right to say, is there any other option? So you could ask that question. I don't know how order we're going. Okay.
I had major surgery 5 years ago, and I knew from prior experience that I was concerned about nausea from general anesthesia. And when I spoke to the anesthesiologist about it ahead of time, which was very nice, they actually adjusted the anesthesia. I don't know if they added something or if they changed the formula.
Yeah.
And I had no problems at all with nausea from the major surgery.
So if you allow me for a couple minutes, tell a story about nausea, because I think it was very interesting. So nausea was something that anesthesiologists didn't care too much, because up to the 90s, mid-90s, if you were coming for a hernia, you come to the hospital the night before and you stay in the hospital for a week. So you're a little sick at the hospital, who cares? Right? All of a sudden, we go into ambulatory care, and I had to get you out of the ambulatory center at 4 or 5 in the afternoon, and you are sick, and I cannot get you home. So a lot of literature came out in the late 90s about prevention of nausea and vomiting. It's also one of my best friends, Alex McCarry from Stanford, wrote a paper where they asked people minor complications of anesthesia, from bruise on your face to nausea to headaches to other non-life-threatening complications, and they say, if I give you $100, how will you distribute that money to buy those complications? And people put the most money on not being sick. So with studies through the years in anesthesiology, and I think I want to get a little advertisement for my society. This is the differentiation between being a physician anesthesiologist versus an anesthetist or a nurse anesthetist. So we did research where we look at the risk factors, and we found that if you are female, if you are young, if you have certain types of surgery in your ears, your eyes, or gynecological or plastic surgery, if you have inhalation anesthetic and a lot of narcotics like morphine-like, your chances of having nausea are much higher. Also, if you have a prior risk of nausea. And what we do nowadays, if you have 3 of those factors, we will prevent the use of medications that may cause nausea, use of medications that are less nausea prone, and also add medications that will prevent nausea, so that you hopefully will not have it. So yes, we do a lot of, and that's I think one of the highlights that we do on our pre-operative evaluation, because again, it's not only on the patient satisfaction end, which is now much bigger than it was in the 90s, but also because it has a financial impact if you're now in the recovery room overnight or need to admit it to the hospital for associated.
I've only had general once,
Mhm.
and I had anyway, I had problems with breathing because the acetylcholine is deficiency. But they didn't know about that before, so they won't use succinylcholine. But they said, oh, there's all this other drugs. But how do I know I won't have some other problem
Okay.
from that?
So just for you, everybody to understand, sometimes when we give you anesthesia and we need to put a breathing tube, we have to we need to paralyze you. So we need to make your muscles get completely weak. One of the drugs that is more frequently used is called Succinylcholine. It's been around for years. And that's basically the first neuromuscular blockade agent that we had. Some people, like the lady, you might have a deficiency that doesn't break down the drug. This drug normally lasts 6 to 7 minutes on your system. You break it down by yourself. If you have the deficiency, if it's partial, the drug might last an hour or two. If it's total, it might be paralyzed for 6 or 7 hours. So that's the only type of drug on that category. All other neuromuscular blocking agents are completely unrelated to succinylcholine, so you should have no problem. But you need to make sure to tell them, if somebody, this is board exam 101, you have pseudocholinesterase deficiency, you're gonna get succinylcholine. It has to be, it's almost like an allergy of sorts.
Yeah.
It's not an allergy per se, but you should say, there should be a warning not to give you the drug.
And none of the other, I won't have any problems.
No, and none of the other medications are related to succinylcholine.
I'm a little confused not having had a lot of surgery.
Okay?
When you go for surgery, you need surgery, you see a doctor, you go to a couple of specialists, you get a couple of opinions, you have a lot of conversations as to what you're gonna do and what they're gonna do. And my experience was, I get into the operating room and then the anesthetist says, well, I may give you a local, I may give you this, what are your thoughts? And I'm lying on the table 20 minutes from the operation. Is the process changing such that you really have a conversation with your anesthetist?
Well, I think it's interesting because if like myself, if I can think of different options on how to provide you anesthesia care, I think the easiest to explain would be if you need your knee to be replaced, I could say, well, we can do a nerve block, or we can do spinal, or we can have you go asleep. Now, ideally, I should explain risk benefits of each of those options and what would be, and I normally would say, well, if you were my older brother, I would select this for these reasons, but these others are equally safe, or if you're prone to nausea, I'll say definitely use a spinal because with spinal nausea is much less. But I think, on the informed consent, which is one of the rights that patients have, my responsibility is to give you the options. So it would be wrong of the anesthesiologist to come and say, we're gonna just put you to sleep if there are other options possible.
When do you do that?
My question is, is the process such that happens?
So I think there are
in
two moments.
advance of
I
the
think there's two moments that you could ask. So if you go into the pre-op clinic, which tends to be now limited for what I call it, major surgery, that might be a moment to ask the person who's seeing you there what the options that you might have, and somebody might explain today. But then the day of surgery, you're gonna see the anesthesiologist beforehand, and they might be asking you that question right there before the surgery.
So the process has not really changed?
Not really changed. But if you go to a pre-op clinic, you could ask, what are the options for the anesthesia? And somebody should be able to explain it to you. What is happening on healthcare, for example, in our clinic, we have a doctor, but we have 3 nurse practitioners who collect the data, and then he's revising all the data of 60 patients that we see in the clinic every day, so he doesn't get to see the patient unless the patient requires to see him. It's a very complicated situation. Or there is some medical legal thing in terms of getting guardianship or to get the consent and stuff like that. But knowing most of the clinics in town, I'm sure that if you ask the question, somebody could give you an explanation beforehand. But if you're coming for ambulatory surgery or didn't go to the pre-op clinic, they're going to be asking you right before that. Let's start here, and then we'll go this way.
You mentioned that anesthesia tends to lower blood pressure.
Yes.
So what happens with people who already have normally low blood pressure?
Okay. So one is that, and this is something in the older adult anesthesia 101, which is go low and slow. So we'll give you less medication and give you medication really slowly, because if I just squeeze the syringe in, you're gonna get all the drug at once. The other thing that we might do is that we might start medication to raise your blood pressure through your vein before we induce anesthesia, so that we raise your blood pressure artificially and then add the medication to it. And that, and that's sounds horrible, but it's not that complicated after you train.
I actually have had trouble post-op because of my blood pressure dropping
Too low.
too low, and it was pretty darn scary.
Yeah.
Even though this was Brigham and Women, they knew in advance.
Right.
They knew in advance. So it's kind of tough. What I'm hearing from this gentleman's question, your discussion, was that there still is an awful lot that happens at the last minute. And you're talking to people who are multiple steps removed from the procedure. And if complications are going to be reduced, that dialogue with the patient needs to be on a higher level sooner in the process, rather than at the last minute, and they're giving you forms to sign, and you no longer have your glasses on, and you can't even read the forms.
Well, this is great to hear, right? Because I have done this since 1997, right? And that's where we do it, right? And there is the, what I call the production pressure to do more, faster, better, right? And for example, the pre-op clinic, I don't have the resources to have more people to see more patients, so we see only the most critical, more complicated ones. We have people calling you home, which is not the same. Even though I'm in paradigms of technology, say, what if I call you home and be in your computer and we have a conversation, telehealth, because you don't want to drive into Boston to see me for 20 minutes, but maybe we can talk on the phone and have that conversation, and that decreases your traveling time, paying $25 for parking, being stuck in the bus by for an hour and a half, getting lost at Tufts Medical Center to see me for 20 minutes. So what do you think about that? Whereas if I say, ma'am, we're gonna call you 3 in the afternoon tomorrow, and you have to be in your computer, and the nurse will, and if you want, the doctor will also pick in and ask you
Sure.
questions.
I mean, it's a conversation at that point. You're not being examined for symptoms and signs. You just need a conversation, so that would certainly work. Well, it was interesting that you said how there is more of a tendency now, at least at Tufts, to do lower spinal for knee replacement surgery.
Yes.
The Baptist, I think it was a few years ago, but they weren't doing that. And originally, when I had knee replacements, I had them done with the spinal, so it was not general anesthesia. The other thing that's changed is, and I want to ask you about this, is why no blood donation? Why can't you give blood for yourself? They used to do that. It seems like they're going backwards, because if you need a transfusion, that increases the risk.
To give you the historical perspective of that was a boom during the AIDS epidemic. Now, the number one reason when we have complications with blood transfusions are errors on the, what I call it clerical errors on the management of the blood. So that means that you might have donated your blood, right? And this blood is labeled under your name. And instead of the blood that I get in the OR, it's not your blood. And there, because something happened, and there's a mistake, right? It's very, very, very infrequent.
Yeah.
I mean, in 20-some years that I have it, but worldwide, the number of cause of complications from blood transfusion is issues with the typing or the blood or the wrong bag, et cetera, et cetera. So, auto-donating your blood doesn't prevent that complication. That's one. Two, being anemic. So if I get a couple pins of blood out of your system and now you come for surgery 2 weeks later, you have not recovered. And anemia is probably a worse predictor of bad outcomes to a certain degree, because that's where carrying oxygen that you need to be circulating for wound healing and getting better faster. So also that process of extracting some of your, I'm going to use the medical term, oxygen carrying capacity, which is your red cells carrying that oxygen so that you get better, might be worse than having your own blood to be transfused for yourself.
I actually memorized my numbers My number, it was like 9 digits when I had my autologous blood donation, and I had them show me the bag. And but during surgery, you can't do that
Yeah.
because you're under, or you're not, alert enough.
We were on this side, so why don't we go 1, 2, 3, so now another back.
I have Parkinson's disease.
Okay,
I may have to have part of the pancreas removed.
okay.
I have had some trouble with anesthesia in the past. What do I need to watch out for?
Well, we have guidelines for which medications you can take. You asked me top of my mind right now, I don't recall them, but we don't want you to have the levels of medication come down too much. We'll be careful with amount of anesthetics you're given. Questions I might have for you would be, pancreas operations and big operations. I would ask about nutrition beforehand, as well as, can I give this out? I'm gonna give you, don't say I say this in public, so the protocol that we use at Tufts is called IMPACT. It's from, and then, so you can ask your doctor where they can prescribe you the 5 days of IMPACT before surgery. And that might help you on the recovery side. I will probably suggest, that's a question that we can do for pain control. They can do what we call an epidural, which is what we do for the ladies going for labor. And will numb the area around the pain site. And that you don't have to get as much opioid-like, morphine-like medications, which might be also interface negatively with your Parkinson medications and your clinician. So I would suggest that maybe after anesthesiology, whereas an epidural is appropriate. As we get older, our spines get stiffer and more difficult to get, so sometimes we're unable to get them in, but I will suggest that in terms of pain control, that may be a good thing for you.
What is it?
It's an epidural. Ma'am.
Yeah, my question is, if you're dealing with a patient who has either mild or more severe dementia, what effect does it have on what you're discussing?
So if you have, I think I touched a little bit about that. So risk factor for delirium or worsening cognitive dysfunction had to be if you have some pre-existing cognitive deficit of any kind. So the things that we can do in anesthesia is prevent some of the medications that we know tend to be associated with more confusion. For example, we call it Versed, which is a Valium-like medication that tends to be in the older adults more prone to cause delirium. There are some medications that we think create less confusion. We might use a little less medications. We might use pain techniques that minimize the amount of narcotics that we use. Unfortunately, that person will probably have higher risk. I also touched upon a little bit on the issue of orientation. So if the person is hearing aids, glasses, family members nearby when they're waking up, if they have lines, tubes and all that, talk to the team about removing those faster. There are things that you can do that sometimes we don't have control to help you, but a room with a window, getting person not to get sleep in the middle of the day, or try to keep them awake so they have a better sleep cycle. All those little details help, but unfortunately they'll have a high risk of having issues, which might be an acute phase delirium within the first 3 days from the moment they finish the operation, or that you notice a month later that their activity has decreased. So that's what I can tell you about that.
Yeah, sort of similar question. My mother has been a frequent flyer to the emergency room for various reasons, and this has been actually very useful because it explains sort of what happened on one of the times where it went very badly and she was really out of it. But what I wanted to come back to is she's also diabetic, and what I found is, I tend to, I'm now like there, I have to be her second backup brain, so when they ask her questions, she answers them correctly, or at least I answer them accurately, maybe the way to put it. So when she goes reeling off, and imagine when she wakes up, they ask her questions, is it like, are they actually gonna get the right answers? And then part of it is then they also, is there a range when you're doing surgery where you try to keep your blood glucose numbers? Because I've also found that as soon as they hit the hospital, the numbers go flying out, nobody really pays attention to them. I mean, as
Yeah.
long as they're not like in the 400s, everybody's happy, which is sort of, I try to keep her in a control range when she's home,
Yeah.
because I'm doing that for her now.
So on the walls that I live the most, meaning the operating room and the ICUs,
Yeah.
we're very tight to keep glucose control because there's solid data suggesting that the outcomes, especially in terms of infections, are better if you glucose control in the ICU and even in the OR in terms of healing of the wound and all that. So we have protocols to keep the glucose control. We use insulin infusions.
But I mean, number-wise, are you keeping like under?
150 to 200 is the range that I'd like to see
Okay.
them
So
myself.
that's the number I keep hearing, and I keep going, that's just
Yeah.
something else the other,
So,
that is what the people are shooting.
The tricky part with controlling sugars in the hospital too tight is that whereas 200 is not good on outcome-wise, but you're not gonna die with a glucose of 200, but somebody can have a really bad outcome if your glucose crashes. So that's kind of, and the traditional teaching, say when I was a surgical resident in Miami in the 90s would be, just make sure the glucose is not too low. We didn't care too much if it was a little high.
Mhm.
But we know, the literature suggests, at least on the perioperative surgical anesthesia time and the ICU, that glucose control is related to good outcomes, provided that you don't make it too low.
Do you guys do like a pre-op and a post-operative sort of cognition test?
Very good question. So, I think that the leaders right now in the country is probably University of Florida, and it's one of those things that happened by randomly. So the pre-op clinic is next to the cognitive dysfunction clinic. So they have a great collaboration. Now, the question is, how do you do this? Because if I have to do complete cognitive function test, that takes hours, and we don't have it. So in the University of Florida, they do something that is probably a bit too long, but they do what is called a mini mental test. So they might ask you to draw a clock and put the clock around that. They might ask you they give you 3 words and you have to say them back and forth, and they have something else. At Tufts, we use something that's called the DEAR score, and it's basically, we look at your comorbidities, if you have substance abuse issues, if you have depression, or you have prior cognitive dysfunction. And if you have any of those factors, we put a flag. And this is mostly a pilot in total joint surgery. And then what's gonna happen with the flag is the geriatrician will follow you with the surgical team post-op to kind of detect whereas you are having a cognitive issue. That's mostly for delirium. For cognitive function, it's even more complicated because those studies are really extensive, might take an hour or 2 per person, and then you'll have to repeat them in different intervals. You'll have to do it in a week, in a month, in 3 months, in 6 months. And to make it even more complicated is that there are several neuropsychological tests, so the literature have 3, 4, 5, 6 different ones, so nobody really knows which one is the best. There's some work that came from the University of Florida again that have one, but again, it's still, you need almost like a separate consultation and a long-term follow-up by a neuropsychologist to see if there is a difference. And sometimes the difference are subtle, sometimes the difference are major. So it's very, and again, from the University of Florida, their papers show that if you low educational substance abuse, prior cognitive function. So remember that slide about your cognitive reserve, right? So if you read, if you sing, if you play games on the internet, if you communicate, you'll want to have more cognitive reserve. So people that have lower educational levels, have depression, might have less of a functional cognitive life, so they're a higher risk to have complications.
I just want to say that all I know is that when her blood glucose runs high, the whole diminished cognition things kicks in, and I know it well enough now to say yes and no, but nobody else would necessarily pick that up, and she can fake it really well.
So, but I'm going to say also this, right? And this is a little bit on the partnership. I think in this country we have evolved where the patients and their family members should be empowered to ask the question, say, why is my mom glucose 400? I think that's not good for her. And if they say something, you say, well, can I speak with the doctor? Who's, you know, if the nurse say, I don't know, you say, no, can we call the doctor? I think this is not good for my mother. I think that you should be empowered. I think, you know, I mentioned that little cartoon, so I think this baby boomer generation, I mean, you guys were the great, I wish I was a baby boomer, right? So you have a voice, right? And you as a patient, you have rights, and you need to be listened to, right? Because a lot of times, you have the answer to the problem. We just, sometimes we're not so good at listening to you. Man.
It sounds like, you know, if you have an older relative, let's say, who breaks a hip, you might not be worried about mentioning that they're at the beginning of dementia, because you're just worried about this physical problem, but it sounds like that's something that should be mentioned.
Yeah, I think that is, well, the hip fractures themselves are a very fascinating topic right now. So the things, my recommendations would be to mention the cognitive function bill. The other thing is ideally they should have surgery fast, unless they have a severe cardiac issue. If they have some minor cardiac situation, that should be able to be managed, because the longer that patient is unable to move, the more the complications they have. So we're powered out of a protocol from Canada, and you know, I don't know, you don't live in the medical world so much, but they put these names on the trial. So this is called a hip attack. So that we, as soon as the patient hits the ER, we literally attack the patient to try to get into the operating room as soon as possible. But unless there is, you know, somebody might have a really bad heart condition at the moment that needs to be stabilized first, but ideally fast interventions have been shown significant better outcomes.
That's it. What fast is like, you get to the emergency room and they diagnose it and they wait overnight and go the next morning, okay?
What time of the day? So we, I'll say right now, if in our pilot Dutch protocol, if you come within business hours to the ED, meaning 7 a.m. to 4 p.m., we probably try to do the same day. If you had if you had to see the medicine doctor, the cardiologist will try to do it within 24 hours. Traditionally, we have waited a day or two, but that's length of stay after a hip fracture have been shown to have worse outcomes. Because immobility, I didn't mention here, but you know, if I put a cast in anybody's arm, you know when you took the cast off that your muscles are all weakened. That happens really fast as we get older. So a day or two of being on a bed, the amount of muscle breakdown that you have is humongous, because also your body is trying to compensate for the fracture, so it's breaking down your muscle. And one of the major issues with older adults are falls, and a lot of the falls are related to either arthritic issues with your joints, but also muscle weaknesses. If you lost your quadriceps, you might fall. I don't know if you remember a video years ago, Fidel Castro coming to the stage and he falls, and that's basically showing he was getting old and his quadriceps, so he's trying to walk faster than he can, and his muscles didn't support him, he just fell.
Oh, God, yeah. It's somebody else.
So when I had my surgery 5 years ago, somebody gave me a book called Preparing for Surgery by Peggy Huddleston.
Yeah.
Excellent. I found it an excellent resource. All of the new stuff was highlighted in there in terms of what to do. It was really, really useful. She had a couple of other dimensions that she spoke to. One was social support. That feeds into the worry aspect, but also the social support, you know, really seems to alleviate anxieties and help a lot. And then the other one was might be called spiritual sustenance. If you have a religious tradition or if you have a faith tradition, really leaning into that in the preoperative period and postoperative period can be a real help. It certainly was to me. So I might think about adding an F to the new.
Okay, all right. You know, this whole concept was new for me. Years ago, I was recruited to move to California, and Don Michael say no. But the clinic in Irvine, and at the time I thought like, here's California, here's guys, right? They have a body and mind preoperative clinic. And they will, you know, some of the aspects you mentioned, so they say mind, body, but also faith and social support. So, and I thought, in a way they were pioneers on this, this part of the worry. And they had, this was around 2009 when I was, considering that move. And they had a clinic there, and this was probably almost 10 years later.
I was incredibly lucky because my wife and I took the UMass mind-body stress reduction program, the DSR program. Finished it 4 months before I was diagnosed with prostate cancer, so it's very time.
Okay.
So is there any benefit, I asked the surgeon, this is for me, I had a spinal for the knee replacement, it was great. This is a different surgery and a different surgeon, and he wants me out. Is there any benefit? I didn't know how hard I could.
So, that's a question of type of surgery, right? So, spinals have limited amount of time where they work and they'll withdraw. There are possibilities, as we call a combined spinal epidural, so we do a spinal and then put a catheter and treat you with an epidural. However, if the surgeon is anticipating too long of a surgery, a lot of blood loss, probably the safest might be a general anesthetic. So, but that may be a question to discuss with your surgeon and say, are you sure that my only option is general? What about a spinal or even a combined spinal epidural? But I always say that anesthesiology, we have two clients, right? We have the surgeon, the patients first, or two customers. We have the patients first, but my second customer is the surgeon. So we also need to make sure the surgeon has the best conditions to do their trade. So that, I'm unable to answer you.
Hi, Ruben. I just wanted to tag on to what you said about the Peggy Huddleston, because I think one of the great benefits of it was that it encourages you to dare to imagine that everything will go well. Instead of sitting in the worry, to keep imagining and meditating on everything going well. And it also, speaking of having your own voice, encourages you to speak to your anesthesiologist and say, I want you to talk to me and give me affirmations throughout the surgery that I'm breathing well, my body is responding, that when I wake up, I will be comfortable, and I think that made a huge difference.
There are even tapes. So I had patients that asked if they can bring, well, I want to date myself here, their Walkman, but I guess now their iPhone or whatever to the OR, right? And they hear,
yes,
a positive reaffirmation during surgery, or music, or something that they like, on those lines.
Yeah, I want to add to that too. The Peggy Huddleston book says, among other things, if you're concerned about nausea, or at least the book of hers that I read, and this was like over 10 years ago, said, if you have to imagine that when you wake up, you will be hungry for something. What will you be hungry for? And they had, when I had surgery, they had somebody, a resident in there saying, what are you going to be hungry for? And then they read what I'd written, which was maple walnut ice cream. So, maple walnut ice, oh, you're the maple. So then I had to have surgery again, just to follow surgery. And I went into the operating room and they said, oh, you're the maple walnut lady. And that was all from the Peggy Huddleston.
Oh, just one more question.
One more question.
I don't know if this is a question you can answer or it's a case by case, but are there any general observations you have about if you're preparing for a major orthopedic surgery? Is there pros and cons of doing a nerve block versus general anesthesia, for instance? Or is that depending on the patient?
So with the nerve block, you have the possibility. So the nerve block sometimes can be used to do the surgery itself. So for example, for hand surgery, we do a lot of regional techniques. This even one that what we do is you put tourniquets and inject Novocaine in your arm and get the snub.
I think you have a nerve block, right?
Oh, then you can do a nerve block. And you can do the first, or you can have the nerve block for pain afterwards. So you might have a general anesthesia or a spinal, and on top of that, you have the block because the pain control with the block might last 16 to 24 hours. I'll say, if you can say yes to a block, say, because we live on the opioid epidemic days, and we are learning now that all that we were taught, almost 20 years ago to say, oh, it doesn't matter, keep all the opioids you can. We're knowing that there are side effects to them, that people can get addicted to it, And I think that it's my responsibility as a physician to try to minimize the amount of opioids you get. Also, the pain control with the block is very solid until the blocks wear off. So you need to kind of start sensing when the pain starts, or you feel some tingling coming back to your knee or your arm or whatever you had the block to, and take some Tylenol or take ibuprofen. But I think the blocks are great in terms of pain control because they help us minimize the amount of narcotic medication that we'll give you.
Thank you.
Well, thank you again very much.